Hi, Regina. Welcome to the Big Unlock podcast. I am Rohit Mahajan. I'm the managing partner and CEO at Big Rio and Demo Consulting. It's so nice to have you on the podcast, especially that you are a practicing physician. Would you like to introduce yourself to the audience, please?
Well, Rohit, first of all, thank you so much for having me, especially since I am a practicing physician. So I'm not, a technical founder or somebody sort of in a data world full time. But for you listeners, I'm Dr. Regina Druz. I'm a cardiologist. I've been a cardiologist since 2001. Board certified cardiologist with all the bells and whistles. I've gone, through all the traditional cardiology training and worked primarily in hospital settings, academic settings, some private practice settings. And sort of along the way, during that journey, ended up going down the entrepreneurial route, and it led me to personalized precision medicine, longevity medicine, and iterating, I guess, on what I think cardiology should be. One of my colleagues, he calls it comprehensive cardiology, but it led me down the path of trying to redefine what is it that I can bring to patients and how they can benefit outside of a more traditional, expected sort of type of care.
That's very cool, Regina, to know that you are now on the path of your entrepreneurial journey as well. So tell us what attracted you to healthcare in the first place. How did it all start?
Good question. So, my parents are not physicians,
Hmm.
but I grew up with really amazing role models. My aunt and her daughter, my cousin, they both were really, I guess, the original power women. Back then it wasn't a term,
Hmm.
but they really embodied it. Both of them were physicians. They were actually obstetrician gynecologists, and really great at what they were doing. They helped a lot of women. My aunt in particular, at the time when she was educated, she was actually asked to go to an underdeveloped country to help to build healthcare there, to improve obvious maternal mortality, believe it or not, because a lot of women at the time were dying in childbirth. And so
Yeah.
she was one of those people who was able to bring in some new practices and help in that location to really improve care for women and children. And so they were amazing role models. And since I was a young girl, I said, well, I'm going to be like them, right? I'm going to be a doctor. I'm going to be strong. I'm going to go ahead and cure the world. My father is an electronics engineer. He was trying to sort of push me a little bit more toward the technical side. And I love science, and I did good at those technical disciplines, but it was biology that really sort of grabbed
Hmm.
my attention. And so the rest of it was pretty conventional. I went to medical school, I went to residency, I did my fellowship, and did not ended up being a gynecologist, which is what my family was a little bit upset about, because they said,
Right.
oh my goodness, you choosing to be a cardiologist? Who does cardiology? You're a woman, and I said, well, women actually do cardiology. And luckily, many more women have been coming into cardiology in the past, we're going to say 20, 30 years. And, we are seeing this momentum building where specialties that maybe were traditionally more inhabited by men are more welcoming to women, and women are able to make their mark. So that's me
That's
in a
very cool.
nutshell.
That's a very cool journey, Regina. So you talked about something in your introduction which caught my attention around personalized medicine and longevity, right? So I know that you have been talking about these subjects, on other forums as well. So please tell us, like, what does it all mean and how is it coming together?
So it's a great question, Rohit. So maybe what I'll do is that I'll take you back a little bit to some of my more traditional cardiology days. So when I was working in a hospital setting, I was actually responsible for an area that was involved with what's known as cardiac imaging, right? So we have various procedures where we can image the heart, understand how it functions. Are the blood vessels open? Are the valves doing okay? Can we discern things about things that are happening now? Or maybe we can sort of foresee the future and understand what's going on. And my particular area was an area called nuclear stress testing, where patients typically they had to exercise on a treadmill. That was part of a stress test. And for those patients who couldn't exercise, we used, what's called a chemical stress test. But the majority of them were exercising on a treadmill, and we would inject a little bit of radioactive material to see how the blood flows into the heart and give them an idea, is their heart healthy or not? And so the interesting part that came out of it is that we would, as doctors, myself, I was already, an attending doctor, and I had younger doctors in training working with me, residents, fellows. We as doctors, as cardiologists, we were a bit biased because we would expect that, younger people would do better. And, you expect younger people to do better. They have more of a cardiac reserve, and that older people will not do as well. But from time to time, and it wasn't, rare, it was maybe, let's say, 20-30% of the time, we would get the opposite. We would get
I,
an older person who did so much better than they were supposed to, and a younger person who did very poorly. And so it started sort of in my head. I started to ask myself, well, is there a pattern, right? What are these older people are doing that helps them to preserve this physical ability, this wellness, if you will, into an older age? And what
yeah,
are the younger people doing, or more like not doing, that actually takes away from what we think they should
yeah,
be able to do, right? Cardiac
yeah,
wise, physical wise.
yeah.
And this was the beginning of a journey into personalized medicine. So, what happened after that is that I started asking these patients questions that were not part of our standard intake, right? Do you
Mm-hmm.
exercise at home? Do you garden? Do you travel? What do you like to do? What gives you purpose? And so all these different answers came into the mix, and I started looking at other physicians that may have gone, before me. Some were actively in the process. Some already sort of were established in their practices, who
Mm-hmm.
introduced this idea of N of one, right? Of personalized medicine,
Mm-hmm.
that there are reasons, there are system biology, root causes that are driving health and longevity, also driving disease, obviously, right? The reverse side of it. And it's not, standardized. It's not a population-based metric. It's literally the N of one, right? And so that piqued my curiosity, that piqued my discovery, and I decided that the best way for me to address it is to take what I know in cardiology and bring it into this more personalized medicine approach. And the best fit for it was integrative and functional medicine, because that's where we could, expand our lens, if you will, and look beyond just, hard numbers, let's say like cholesterol or blood pressure and medications that we'll give a person, but ask ourselves, why is their blood pressure elevated? Why is their cholesterol elevated? What can we do about it lifestyle wise before medications or even with medications to help them not only to have a better number on a blood work, but actually optimized health, right? Because at the end of the day, optimized health is one of the major contributors to longevity. It's not the only one, but it's really the physical health, cardiovascular health, brain health, systemic health is really the foundation of any longevity equation, right? You cannot talk of longevity if a person's
Right.
health isn't optimal. And so
True.
that was the beginning of kind of
Yeah.
going off the beaten path.
Yes.
My colleagues were absolutely horrified. They thought
Yeah.
that I got completely crazy because they could not understand it. They said, you have such great credentials and all these roles, like, because at the time, we're talking like, 10 years ago, at the time, there was really no room for this in the institutional setting.
Right.
There could have been some departments, sort of a little bit more, inclined toward, let's say, integrative or complementary medicine, but there wasn't nothing institutional. So what that meant is that one has to go on their own, right? And that was at the time when, medicine was beginning to consolidate. So people said, you're absolutely insane, and, you are basically going to just do very poorly. And I opened my first tiny little practice with about 3 patients in an area that was absolutely saturated with cardiologists even back then. Today it's like exponentially so. And I'm here to tell you that this works. And this was not
Mhm.
only a huge
Mhm.
benefit to my patients, but it was a
Yeah.
benefit to me,
That's
right?
that's awesome. That's awesome, Regina. And I know that you're very interested in all the new technologies coming our way. And in any podcast these days, we have to touch upon AI. So how do you look at AI and digital health from the lens of cardiology? Like, what does it mean to you? And how do you see some use cases, both from a physician-patient perspective and caregiver perspective? How does it all play out in your world and in your
Yeah,
mind?
so it's a great question, Rohit. And I was an early adopter, so I think, back then there weren't as many things available to us. Right now we have so much more,
Yeah.
right? And I
Yes.
think any digital health sort of domains, if you were to look at them in cardiology or even any other specialty, you have to ask yourself, how do they benefit a patient, and how do they help doctors, patients, and nurses to really do the right thing without burning them out, save us
Mhm.
on cost, and potentially fall into regulatory compliance, right? Because we cannot do things which are sort of outrageous and could harm patients, cannot be regulated. So I started with telemedicine. I was an early adopter. And since my practice was personalized, telemedicine, as you know, it's a great tool. It gives
Yeah.
patients a lot of access, but it's something that it has an Achilles heel, right? It has a major deficiency. And the major deficiency in telemedicine is the fact that you're not getting a physical exam, right? You can't listen to a patient, you can't really do any of those things. And so
Mhm.
I started for myself trying to figure out, well, how can I overcome that barrier? Because
Mhm.
I need their blood pressure, I need their electrocardiogram, I
Mhm.
need a couple of other measures that could tell me are they okay or they're not okay, right? We need some sort of a baseline. And
Mhm.
so this led me then to explore, well, what are those digital tools that we have available? And there are quite a few. For example, there is a company called Alive Core that was also fairly early on the scene, and they
Mhm.
created a little device, which I believe I still have the original, but since then I have a couple more, and
Mhm.
it was basically would clip on the iPhone case, or you could get it as a case for a mobile device, and you
Mhm.
literally would put 2 fingers on 2 little metallic plates, and it would record a single lead electrocardiogram. Now, it wouldn't be a full electrocardiogram, but it was the beginning, right? At the
Mhm.
same time, for example, other companies, and there are a lot of them now, but there are some very big ones like Omron, Whittings, they
Mhm.
would come out with Bluetooth-enabled blood pressure cuffs. So a
Mhm.
patient could check their blood pressure and transmit information to me, right?
Mhm.
And so for the first time ever, I wasn't blind
Yeah.
anymore, right? With that telemedicine adoption. And
Mhm.
actually, when COVID came and, a lot of institutions had to cancel in-person visits and as practices, but to cancel in-person visits, I
Mhm.
wasn't really stuck because I already had the
Yeah.
telemedicine platform and I already had some of the tools. Nowadays it's even much more diverse than this. For example, I routinely use the tools from these companies that I already mentioned. Now we can do, for example, a Bluetooth enabled 12 lead electrocardiogram with a live core, and there is no electrocardiogram machine. The whole
Mhm.
setup is just looks like a little remote controller with a button, right? The ultrasounds that we use in cardiology, vascular ultrasounds, cardiac ultrasound, it's called an echocardiogram. There is a
Mhm.
company called Butterfly IQ that
Mhm.
literally has ultrasound on a chip. So it connects to my phone or an iPad, and I
Mhm.
don't need a machine that costs, 6 figures. This little
Mhm.
contraption is very affordable and it gives me diagnostic quality images. So I think what we're seeing is that the digital devices, they went into the hands of practitioners and then they became available to patients, because patients nowadays, they use an Apple Watch, they use a
Mhm.
Winnings watch, there are all sorts of monitors and trackers like Fitbits,
Mhm.
for example. There's just a whole universe of these devices. So all
Mhm.
of a sudden we're now getting these streams of data that are just overwhelming because they're coming from all directions.
Mhm.
And then to compound this, AI came back into the picture, right? So now
Yeah.
what patients are doing, they are doing what I call being a citizen patient, right? Like citizen
Mhm.
scientist who goes and
Yeah.
investigates.
Mhm.
Citizen patients investigate themselves. They upload all of those reams of data
Mhm.
into one of the large language models,
Right.
and they have the large language model give them an output. Whether it's correct or not, they don't really know, but they like the fact that they have this agency, right, to do
Yes.
this. And at the same time, we are seeing, I think, an evolution as these data streams are becoming, part of routine medical practice. We're seeing evolution of this, with places, for example, like Mayo Clinic,
Mhm.
using these large data repositories and AI tools to
Mhm.
analyze electrocardiograms and predict heart failure occurrence years
Mhm.
before heart
Mhm.
failure symptoms even appear, which is
Mhm.
an enormous opportunity, right? Because we could work with individuals who are at high risk preventatively to really spare them the clinical
Mhm.
syndrome of heart failure. And we know, for example, that once a person presents with their initial episode of heart failure, their mortality rate is 50% at 5 years. So
Mhm.
imagine if we could, be ahead of this curve 10 years
Correct.
before, 5 years before, right? So I think we are evolving from just curiosity to
Mhm.
clinical implementation, and hopefully down the road to clinical competency that will become part of
Mhm.
the standard care, not sort of like nice to have, but a must
Yes.
have. And there is a lot of it already, been kind of put forth regulatory wise, because there was a recognition that these devices are helpful. And so there is, for example, Medicare pays for something called RCM, which stands for remote care monitoring. And
Mhm.
this remote care monitoring usually is reserved for higher risk patients, but it is
Mhm.
accomplished through these digital devices and AI interfaces that could
Mhm.
allow us to identify what's happening, right? So that's sort of like our third eye, if you will.
Yes. Yes. So that's pretty deep usage of, you know, AI and digital devices in a variety of different ways that you're looking at. So, Regina, one other thing that I know, you mentioned large language models. The other thing which has become very popular is all the aiding AI coding tools, right? And we were just chatting before the podcast. I have now several physician friends who have started experimenting with such
Yes.
coding tools. So tell us your experience, and you were mentioning an article also. So tell us more about what you are seeing in this space. Yeah.
So this is very interesting, because obviously when ChatGPT sort of became a household name,
Mhm.
I said, okay, let me give it a crack, right? And it was an interesting experience, because at the time I was studying for the boards, and so cardiology boards, they have different ways for you to maintain your board certification. One of the newer ways is that every year you do a small piece of sort of cardiology knowledge, and you pass that small exam, but you do it on a yearly basis. And so
Mhm.
it was time for my exam, and I was studying for it and using sort of traditional stuff that, that we typically study for it with American College of Cardiology. But some of the explanations to the questions and the answers left me, wanting a little more. So I started putting those questions into ChatGPT,
Mm.
and lo and behold, it would give me very deep and nice and long enough explanations that would actually uncover some of my blind spots. And I said, "Oh, that's interesting." So,
Mm.
so certainly, I think LLMs, when they don't hallucinate, are great,
Yeah.
educational tools, right? And you can
Mm.
you can constrict it, and you can say, "I only want you to look, at such and such journals or such and such guidelines." But I
Yes.
think the real breakthrough for me as a practicing clinician came from, so there were two of them. One as a practicing clinician, and one sort of as a clinician entrepreneur, if you will. But the real breakthrough for me came from ambient AI scribes. So
Mm.
the ambient AI scribes became indispensable part of my practice.
Mhm.
There are several companies. I personally use some, company called Heidi Health. I'm sure they'll be thrilled that I mentioned them because they're, sort of a young startup company. They started out from Australia. And what I found, it was something very interesting. So most people feel that, the ambient AI scribes, they will do a good job catching the conversation and allowing you to save time on entering your notes, right? Which
Mhm.
is true. But there was something else that happened. And
Mm.
and that was sort of, unanticipated consequence, or as we say in business, positive externality. What
Mhm.
happened is that the structure of that ambient AI scribe allows you to generate versions of
Mhm.
your notes. And
Yes.
I started to generate a version that I could put in as a message to my
Mm.
patients, because we're all using patient portals, right? And
Yep.
I wanted to make sure that my patients not only read the note, but they
Mhm.
sort of have, a smaller version that tells them, well, those are the next steps, right? This is what I
Yep.
need you to do. This is how we're going to do this. And so instead of me trying to reinvent this, I was able to, after a few sort of poking around in that AI scribe, I was able to generate a template that I liked. And I
Mhm.
feel like, number one, this enhanced my patient care manifold,
Mm.
because this is yet another touch point with a patient. It's another opportunity for engagement. It helped me as well not to have to remember everything, but no, this is the next step, right?
Yeah.
And this, in the area where I'm in, this personalized medicine, longevity medicine, health optimization medicine, this area requires a lot of engagement. This area is very participatory. It's not, in many ways, it's very different from traditional medicine, or let's say institutional level medicine, where, a doctor sort of tells a patient, this is what you're going to do, but they're not necessarily reaching out to patient sort of regularly to check on their progress, right? They wait for patient to take initiative and come back. But when it comes to this personalized longevity medicine, it's exactly the opposite. And that's what I felt those AI scribes, gave me that ability, to not only to be efficient and effective, but use what I call, the famous saying in business, right? The Zappa saying, excite and delight, right? So
Yeah.
this was excite and delight my patient, to give them
Great.
that more communication. Now, as a clinician entrepreneur, I am playing around with agentic AI.
Yeah. Cool. Yeah.
You and I talked about that.
Yes.
It's a very interesting experience. Some of these experiences are really helpful.
Mhm.
And some of those experiences are, question mark, because one of the things that I find a little bit sort of unsettling, and this is an issue that was brought up before by people who are much more knowledgeable in AI than I am, like, the CEO of Anthropic and everyone else, is that AI is sort of a black box,
Mhm.
right? And so we don't have full visibility. So when it provides these answers, especially, let's say, agentic AI, and I asked it for a simulation on a complex patient that, had cardiac issues, but also had other issues that were immune system based, and trying to understand, if I'll put in all these parameters that we know, what can it source as a path? Am I missing anything? And my initial sort of hunch with regards to what needs to be done for this patient was correct, but I wanted some
Mm,
sort of backstory, if you will. And it produced a great output and actually gave me a list of references. It didn't hallucinate. But what I wanted to know is that how did it build the case,
mm,
right?
mhm,
Because in medicine, we know how we need to build our cases, right? Our
mm,
diagnosis, our workup, our prognosis. We have these check and balances, we have these frameworks and systems. They've been
mm,
around for a very long time, right? And we learned the hard way, right? We learned from real patient outcomes. They're not always positive, So that's where I think there is this black box situation with LLMs, whether it's, just an LLM or a chatbot, or whether it's actually more complex and it's doing
mm,
all these agentic functions.
mm,
That's where I feel we are in the uncharted waters,
mm.
because and it's do we will we use them going forward? Absolutely, but I
Yeah,
think we need some sort of visibility as to what these things are doing, for
right.
lack of a better word.
Of course, of course. And then, Regina, I think we had hit upon something that we were discussing prior to the podcast about digital divide, and you said that people with high agency will propel ahead by using such tools. So, could you explain the thought process behind that?
Yeah, so that's a great
Mm,
question, Rohit. So the digital divide very often gets mentioned when, for example,
mm,
we discuss some of these digital tools, right? Whether it's a wearable device or even access to a telemedicine platform,
yeah.
you should always ask yourself, well, will any of the patient groups experience a digital divide? For example, older patients may not be technologically savvy enough to
Mm,
navigate a telemedicine platform if it's a little bit too complicated, right? Or they may not understand how to, include this Bluetooth-enabled blood pressure cuff so that I
mhm,
could see the numbers, right? They can't necessarily figure it out because it has to go through the mobile app, and it has to synchronize. They need to log in, and of course, we have the need to protect data in healthcare. It's a very regulated,
mhm,
privacy heavy type of a field, right? So traditionally, digital divide would apply to older patients, or patients, for example, who, for whichever reason, cannot afford these devices, right? Not everyone is going to be able to have a mobile device that allows all of these connections, or spend money on a more sophisticated type of a blood pressure cuff, when a simple one that doesn't really transmit anything anywhere is basically significantly less costly, right? So the digital divide unfortunately marginalizes older patients who are not, who have cognitive incapacitation, patients who may not be speaking English, patients who don't have access, for financial reasons or logistical reasons, right?
mm,
But I feel like there is a whole other level of
mm,
digital divide is forming right now. And, it's good that you mentioned this, because I read a piece recently, actually yesterday or day before, in Wall Street Journal, on how these AI tools that pretty much anyone can use, because most of the LLMs or agentic AI providers, they have a free level, so anyone could actually go and try it, right?
yeah.
But what the article was saying, that to really use them in a way that propels you forward, these individuals who are using them, they have to be high agency individuals, right? They have to be able to take the tool, give it instruction, understand that it's not always giving you exactly what you want, but work with it and sort of, get the result, go ahead and refine the result and keep on moving forward. And the
Right.
article author called it high agency individuals. And I feel like that I'm seeing this, for example, right now in my patients, right? Because there is a digital divide is deepening in my patients, because those of them that have high agency, who are
Mm,
capable of using these tools, are
mm,
definitely getting more information, more touch points, a different experience in terms of how they take care of their health,
mm,
versus the ones who are not really inclined to use these tools, right? And so, and I think we as physicians are also in a way, entrenching this digital divide. For example, one of my colleagues, a really well-known physician and a former president of American College of Cardiology, Dr. Kim Williams, I had him on my podcast, and he is really one of the champions of lifestyle medicine. He always
mm,
provides lifestyle advice to his patients. He really made it part of his practice. And he said, well, I have my team to help me. And I said, well, who is your team? And he said, my team is ChatGPT. And so what he does, he goes into ChatGPT and he describes what a patient scenario is, not for medical purposes, but for example, cultural purposes, right? He wants a patient to have more of a whole food plant-based diet, but a patient doesn't really like that. So, so
mm.
the idea is, how can you help a patient make a healthy transition without overwhelming them? And that's what he does. And he says, that's my team,
Awesome.
right?
That's awesome. That's awesome. So, Regina, as we are coming to the close of the podcast, I would like to ask you, when you look at the crystal ball for the next few years, let's say 3 to 5 years out, what do you see? And, what are some of the exciting things that you think are coming our way as well?
So
Yeah.
it's an interesting one, because I ask it to myself very often, right? In the
Yeah.
physician community, there are obviously a lot of voices who say, "Hey, AI is going to replace doctors," and then and we have something from a tech world, right? There are some, Vinod Khosla is very famous for saying that there'll be like no radiologists and things
Mm,
like that. And then of course there are other voices that are more
mm,
introspective maybe, and they say, no, AI is not going to replace doctors. But one of
mm,
the things to me is very clear, is that we are going to see in the next 5 years a rapid emergence of agentic AI in all verticals of healthcare. I think it's
mm,
going to take care of things which are sort of mundane, pre-authorizations, appointment scheduling, supply
mm.
chain management, and then it's
Yes.
going to really make its mark in the triage and staffing decision making, right? This is very important, especially during the times when some calibration needs to happen between demand and supply. And then it's going to make its mark, and it's already doing it in the clinical decision support, right? So for example, there is a company called AI Doc that allows radiologists
Mm,
to identify life-threatening pathology on brain scans and neck scans
mm,
that potentially they may have missed, right? So it has, we have evidence that there are AI enabled mammography tools that could predict occurrence of breast cancer before it even happens. There is
right.
an AI tool that allows investigational, of course, but it allows clinicians to predict onset of Alzheimer's dementia before any cognitive decline. So I think, to me, as a personalized medicine and longevity doctor, this is where I see the biggest impact for us, right? Transitioning into this clinical decision support. And I do predict that it will really make this N of one, the
Mm,
personalized medicine, a standard type of medicine, that we will eventually sort of abandon our focus on large populations and even population health, because AI will enable us to address population health differently. We will
yeah.
be able to leverage that small data, that N of one, to build much more enriched type of phenotypes, or whatever we can call them. So the
Mm.
populations as we know them for investigations and providing healthcare, they will be redefined through artificial intelligence. And that, I think, would be a huge impact, on all of us.
That's awesome. That's awesome. So thank you, Regina. This has been a very interesting conversation. Really appreciate it. And any other last comments? Otherwise, I'll close the recording.
No, probably not that many last comments, but maybe I'll take, 10 seconds to address anyone
Yeah.
who is listening who might be a physician or a nurse practitioner,
Yeah.
right? Or anyone in healthcare who has a medical affiliation and, in the back of their mind, they're thinking, should I be doing it? Should I not be doing it? Should I, jump into this entrepreneurial route and see where it takes me?
Yeah.
I can tell you that there are no guarantees, but if you are one of those people and you're thinking about it,
Yeah.
what's that famous saying? The best time was 30 years ago. The second best time is now. It is
Yeah.
now.
Cool. Cool. Thank you, Regina. Really appreciate it.
Thank you for having me.